Now, in the name of the Almighty, the most merciful and beneficent, previously I have shown you some X-rays. Although there are problems of recording on this video because of the audio system is not working properly. Anyway, the X-ray was shown to you. The X-ray was shown to you, and the thing is, the 5 X-rays have been shown. This is section and part 9. I'll try to interpret it for you. A 72-year-old housemaid developed shortness of the breath, the loss of the weight, and a low-grade fever since 6 months. Now, this X-ray has been done, although there is difficulty in doing this X-ray technically, and the important positive finding in this X-ray is, first of all, the right breast is not visible. Probably the mastectomy has been done on this patient. I don't know the history exactly, what happened, and what is the grading or the clinical staging of that tumor which was found. Now, secondly, the finding is this about the bony skeleton. The osteoporotic changes are seen in different zones, and then the soft tissue shadows, one is missing. I already said the right mastectomy has been done. The trachea is deviated to this side. On the right side is 20-degree deviation is there. And you find the lung fields, the apex of this side is hazy, it is not visible clearly. Although this part of the lung, you see the hypertransparency, it is compensatory emphysema because the vital capacity should be reduced. Look, the zones, the first ray, the second and third, is hardly fifth ray. Restrictive type of a problem here because the intercostal spaces are less than 1.5 centimeters and the approximations of these ribs are very clearly visible. And the other findings in X-ray are the appearance of the opacities. Look, these opacities which are visible here. In this, you can see, first of all, look the posterior part of this, upper zone, lower part of the ribs. And you find that the osteolytic areas in the ribs are seen. Probably the patient had developed secondaries in the ribs, and we find also that there is this part, the dome of the diaphragm, the tenting of the dome of the diaphragm, above it you find there is pleural thickening because it is blocked, it is hazy, and one projection is coming out, lobulated, it is pleural thickening. Here is again the non-homogeneous opacity with reticulations are seen. This means that fibrosis or fibrous septars, they are crossover bridges here in this part. The whole of the lung is involved in this case of this right lung. Plus we find the middle mediastinum's right border is not correctly visible. It is silhouette sign because of the pleural thickening is also there, the pleural fibrosis is there, and there is the parenchymal fibrotic reaction is obvious because you see that the trachea is shifted to the same side. So these are the most likely positive finding. All the costophrenic angles of this side and cardiophrenic angle on this left side, they are normal. Depending upon these findings, acute inflammation is not possible, or rather the chronic inflammation is more likely, resulting in the fibrotic reaction. And that is tuberculosis in this country, in our country, is very, very common, and they result in the fibrotic reaction. Remember that coronary can also cause the fibrotic reaction in the lung. Now this is actually which I have gained my experience during the management of the coronary in 2 years. That about 5 to 7% of patients ended with the fibrotic reaction in the lung. The fungal infection can cause fibrosis, but the other part of the lung is not involved. It is the hemithorax, right hemithorax is involved with the fibrotic reactions. The other condition which can cause it may be possibility of some of the allergic reactions, which is possibly of the extrinsic allergic rhinitis. The feature against it is the second hemithorax is not involved. Then the coming the pneumoconiosis. Pneumoconiosis is global in nature actually. It causes the 6 lung fields to be involved in most of the cases. And other conditions which cause fibrotic reactions, possibly the autoimmune diseases can cause the fibrosis in the lungs. And most important diseases, a group diseases which is called ILD, interstitial lung diseases, and causing the fibrosing alveolitis, but the other part is not involved. This like less likely diagnosis, although it is possible. And the chronic inflammation may be caused by the repeated infections of the parasites, which is causing the root, that is the root is enterohepatic, and the pulmonary route of their spread is possible with this. Myxorenal microfilariae can cause the fibrotic reaction if it is not treated. So it is unlikely diagnosis, although it is. So in other investigation you can do the lateral view of the right side. The HRCT is helpful, and the pulmonary function test will reveal the interstitial lung disease, fibrotic reaction, and you can do the sputum for AFB and DR culture and sensitivity. What you do now is that if it is an active disease and you exclude the secondaries in the ribs, which I mentioned here, then the problem can be solved by the increasing the vital capacity, the physical exercises, the chest exercises, deep inspiration exercises, the diaphragm exercises. These are all will help this patient in doing the everyday activity of the life. ADA, that is called activity of daily life, ADLF. So the oxygenation should be properly done. Intermittent oxygen can be helpful. Bronchodilator can be useful in this condition if it is an active disease. You cannot reduce the fibrosis. Which is done. So anti-fibrotic drugs have got a limited role in this condition. A 50-year-old working in the wheat fields presented with a dry cough and the wheezing, especially at the night times, since 2 years. He had also intermittent colicky abdominal pain. Now you see that this interpretation is that the bony skeleton and the soft tissue shadows and trachea is central, because this is an important marker. Trachea is central. You find the lung fields, the apex with the apex, then this first intercostal space with the first intercostal space, you find there is a opacity which is predominant homogeneous, although the few aerograms are seen, and this is what is elliptical type of shape. And down there are bronchovascular markings are thick, and they are touching the 1/3 of the hemithorax, lateral wall. On the other side again the same type of reaction is seen. Or this is homogeneous, not homogeneous. On the same side of the left side, same findings. And she has the claustrophrenic angle of this side and this side is normal. So what happened in this condition is that acute inflammation can cause this type of reaction because it is bilaterally present. So it is least likely that the resolving pneumonias lobar bilateral, very rare. The chronic inflammation is possible in this country, in our zones. So the mycobacterium tuberculosis should be excluded in any way, until and unless proved otherwise. Tuberculosis is a diagnosis, should be included in every differential. It is possibility. And about the fungal infection can cause this type of opacity. Yes, they are. They are causing this type of opacity, and the fungal infections, other than that, it means deep invasive type of the systemic mycosis, I will say. Multiple opacities are more likely findings in the pneumoconiosis are concerned, fungal infections. Fungal infections. And then the allergic reaction, extensive allergic uveitis can cause the fibrotic reaction in the lung, but not in this fashion. Sarcoidosis can cause de-homogeneous or non-homogeneous obesity with the perihilar lymphadenopathy, but the reaction is not of the sarcoid type. The other conditions which causing the pneumoconiosis is not possible because the global findings are least likely, are the more common findings, the least likely in this X-ray. And about the parasitic invasion, yes, it is possibility of this is more likely because look, the dry cough and wheezing, especially nocturnal wheezing, intermittent and chronic abdominal pain. Parasites which are involved are long list: Salmonella, Trichinella, Trichinella, Mycoplasma duodenale in my country, and Mycoplasma duodenale with the Escherichia lumbricoides, which has got the entero and then hepatic, and on the right side of the heart, and then the lungs, and then again the esophagus and stomach. The reaction here occurs, as we call as a pulmonary eosinophilia. So it is possibility that pulmonary eosinophilia will cause this type of a reaction, no doubt about it. Again, because of the nature of the intermittent abdominal pain, more stressing on the invasion of the parasites rather than the other causes of the pulmonary eosinophilia. And that is about the aspergillosis is concerned. Aspergillosis will not cause this type of lesion like this. It is most probably what we call as in our setup we call Lopfler syndrome, caused by the invasion of the parasite. So you manage this case with the deworming it properly. Not the same dose you use albendazole and mebendazole. Higher doses should be used for a prolonged period of time, and you monitor with the eosinophil count. If it's 22%, after 1 month it should be 10%, and after 1 month it will be 5% normal. So the wheezing will go. Symptomatic measurements can be done by bronchodilation, and because it is a sort of allergic reaction, you can also give the anti-mediated drugs like the montelukast, and you can also give ketotifen, which helps in this condition. Preventive measures should be done. Barefoot, they work in the field barefoot. They should wear the proper stockings and shoes while working in the fields. So the next X-ray was a 52 years old zoo worker developed diaper. He's a worker in the zoo with dry cough and the wheezing and the shortness of the breath since 5 months. The patient is not so ill than the X-ray. X-ray is very bad. A lot of findings are there. Look at the findings. Trachea central, the other parameters are normal. Right hemithorax, the upper middle lower zone, nothing is seen here. It's all on costophrenic angle, cardiophrenic angle is normal. And this side, costocardia is normal, but there is a big homogeneous opacity from upper zone, lower part of the upper zone, involving whole of the middle zone and the part of the lower zone. Look, the margins are very regular, and there is a slide here. This part shows the aerograms. Now this is the differential diagnosis you will make, because the border of the heart is visible. Look, the left border, it is touching it, but the border can be differentiated. The right border is visible very clearly. Upper part of the mediastinum is normal, and there is no pushing effect of this so big mass. So heart is not pushed, even the trachea is not deviated toward the other side. Interesting situation. So big mass, patient is not very symptomatic. So it is acute inflammation. Let's see the differential diagnosis. Acute inflammation can just a big abscess if it is there as a result of the global pneumonia. The fluid level is seen although, but the patient is not symptomatic. She should be a fever with a high grade fever, etc. And erosion is more common, hemoptysis, pleural expectoration. Chronic inflammation in this country is common. Tuberculosis can present any opacity, remember, should be excluded from the tuberculosis. Although the tuberculosis will not form this type of the opacity, the cavitation full of the exudate. It's possible because this part had got aerogram. So it should be excluded, although it is not the main diagnosis. Fungal infection can cause the big opacity, but it should be multiple opacity rather than a single opacity. Now, about allergic reaction are concerned, extrinsic allergic urethritis will not present like that. It may be the eosinophilic granuloma, it is possible, yes. The eosinophilic granuloma is associated with the pulmonary eosinophilia. And then you go for the other differential. Interstitial lung disease will not cause this type of lesion. Pneumoconiosis, no. Sarcoidosis will not cause this type of lesion. It is least likely. More likely the parasitic invasion, and it may be a big hydrated cyst. Although the exocyst and the endocyst are not here, there is calcification. I will see here this part. Starting calcification is a benign lesion. It may be bronchial adenoma, it may be a hematomatous cyst even. But because of the history which we have given just now, it may be the hydrated cyst. So hydrated cyst, the other investigation, the left lateral view, helpful, HRCT will be helpful, sputum for the GR and AF, which should be excluded with the gene expert, and go for the other in specific serology for the hydrated cyst. ELISA, D-dimer, and immunofluorescent techniques have been used. And the management part is that this part is a very big one. So in the American zone, they like to remove this part as much as they can. Cutting this part here and this part here, all should be removed and biopsied. Rather we go for the pharmacological intervention in our country because lung surgeries are rarely done. Thoracic surgeons are very rare in this country who do usually practice the pulmonary surgeon. They are doing the pulmonology rather than the surgery. They avoid surgery in most of the cases. So we gave the pharmacological intervention. The high dose albendazole, high dose mebendazole should be used or for a very prolonged period of time to reduce this cyst. Measure it, count, eosinophil count or the monitor, and then do it with the pharmacological intervention. Another X-ray has shown a 44-year-old crane operator developed fever, cough, and weight loss since 4 months. He noticed dark brown colored sputum, which only means that some hemoptysis has occurred. With this X-ray, all parameters are seen. The trachea is shifted towards the right side, about 20 degrees, and the apices are normal. Apices are normal. The first intercostal space with the first, second with the second, third with the third. Going down, and the third or fourth intercostal space from here to here, you see the opacity. Down there is a slight haziness as seen. And claustrophrenic and cardiophrenic angle normal on both sides. Only the big allogram, gastric allogram is visible. The lower part of the middle mediastinum, that is the cardiac shadow, look, the border, the left border of the heart is not visible properly. It is gone. So there is still hot sign here. Right border is visible, left border is not visible. The apex is gone. The upper part of the left border is gone. It is not seen. The upper part of the middle mediastinum should be divided into 4 by imaginary line. The first part will represent the ascending aorta. The second and the third will be the arch of aorta, and the fourth one is the aortic, the pulmonary knuckle, that is called a pulmonary conus. Aortic knuckle is there, pulmonary conus behind it, just below it. Nothing seen here. Rather than this, look, this opacity's margins is going outwards, moving here and here and here and here and here. It's going up with parallel to the trachea. Big opacity. It is the upper mediastinum, and this is the lower mediastinum. So this part is some part is visible, although later we will show it clearly, but it is the anterior mediastinum or middle mediastinum or posterior mediastinum, but most likely it is middle mediastinal shadow, and it is a big mass is there. This mass may be possibility of the acute inflammation. No, it is this likely. What about chronic inflammation? That is, tuberculosis must be excluded, although atypical. And what about the fungal infection causing this type of reaction? Least likely. Tumor and a tumor-like state, the bronchogenic carcinoma can present not like this. On the one side it will be, not on the other side. The margins are very regular. It's not very irregular type. And there is no secondary effect, only one is trachea shifted, that's all. And there is Seller's sign. So, benign tumors of the possibilities of the arising from the mesenchyme, and mesenchymal tumors are possibilities. Most probably here is mesenchymal tumor, some of it. There are a lot of the mesenchymal tumors arising from this area, which I mentioned it, upper part of the middle mediastinum. So this is probably the mesenchymal mass or a tumor which should be investigated further. The allergic reactions of sarcoidosis are concerning, and the interstitial lung diseases and the parasitic invasions are not looking this type of reaction. in the lung. So this is most probably diagnosis is a mass probably arising from the mesenchyme, is a mesenchymal tumor which should be investigated further with the HRCT, and we go for the CT guided biopsy or bronchoscopy and take the sample and do the biopsy. Other routine investigations should be done along with that. Sputum should be done in this patient to exclude tuberculosis, because it may be a tuberculoma, a big tuberculoma, although it is not very common presentation of the tuberculosis. So the thing is this: if it is found to be a mesenchymal tumor, then we grade it, and then it should be clinical staging should be done. Looking to meet this clinical staging, here is what is called the size of the tumor is big one is a T3, and number of lymph nodes are not involving. I have not seen here any lymphadenopathy, and not metastasis is not seen again. It should be removed surgically and managed afterwards. But this part should be removed, and proper compliance should be done for this patient. If it is definitely a malignant, go for the chemotherapy or radiotherapy as indicated. So these are the actually another one of 52 years old clerk developed remittent fever, loss of weight, and dry cough with the breathlessness. To me, this actually seems to be a normal one. But on the very close look the trachea and the apices, first intercostal space with the first, second with the second, third with the third, and downwards costophrenic, cardiophrenic angles, etc. And the middle mediastinum lower part, the hard shadows, and the upper part of it. So I picked the abnormality here. Now, upper part of the middle mediastinum is this one. Now look, this is the first part, this is second and third, and this is the fourth one. Here's the aortic knuckle. This is the aortic knuckle. This is the trachea. Always remember, on the trachea of the right side, you see a linear shadow is going up here, up there, from here to here. Now this linear shadow from here to here, this is a paratracheal lymphadenopathy in this condition. Although this patient may show the cervical lymph nodes which are missed in the scenario, and the hyla, they are prominent hyla, although not enlarged, but they are prominent hyla which are seen. But the main thing is the paratracheal lymphadenopathy. Remittent fever, Palestine type, loss of weight, dry cough, all are in favor of lymphoma in this condition, and it's probably the Hodgkin lymphoma. You do the HRCT, you do the CT guided or the transtracheal biopsy of the lymph nodes, and then grade it, and then clinically stage it afterwards, and then go for the therapy. Start therapy for this patient. Very effective therapy can be achieved. The goal can be achieved, and the outcome is good if you picked up early and manage it early. The other markers, CD markers, can be done to classify this tumor. Lymphoma classification is very difficult. It's not easy. Although, so it should be classified properly, and then manage it with the chemotherapy. We have tools of the chemotherapy and radiotherapy or surgical intervention. Surgery is not indicated, chemotherapy yes indicated, the CHOP therapy or something like this, and radio chain can be done if it is indicated. So these are the axes which I have discussed. 5 axes I have discussed very not done a brief account, it's a slightly detailed account has been given, because the last one was not an easy one. So inshallah I will next day I will go for this last session The least 10th session will be started. So about 46 X-rays or 47 X-rays have been covered. And these are enough for the to appear in the examination of the fellowship examination or diplomate examination or the MRCP examination. X-rays. All X-rays have been shown to you, commonly given to you, to interpretate it. So we'll see you afterwards. Good day, good night, and wish you best of luck.